My task is this time to remind you what are the options for anterior approaches to craniocervical junction. Although we don't use them regularly, especially in buzzer invagination, but we may use them in other diseases like tumors, infections, and irreducible pathologies. These are the options. You can come from 2 up, like transmaxillary, then transoral, then extrapharyngeal, and transmandibular options. The main indication, as I said before, are tumors and non-reducible pathologies like trauma or buzzer invagination, which is, according to Atul, it is very rare, buzzer invagination, which cannot be reduced. Very commonly known is the transoral approach, but you can also use anterior, retropharyngeal, or lateral approaches. This is one example that a C2 tumor. I have done it in 1990s, but just a transoral resection and then cement application and a key wire inside the odontoid process. So this patient had 5 years follow-up, no recurrence. After surgery, she had a radiotherapy. Currently, we have also some endoscopic surgeries for anterior approaches. But I will tell some nuances of them and advantages and disadvantages of them. Transoral microsurgical approach is the most common one. You can go to by a tongue retractor, especially that the most well-known retractor is from the Crocart. But there are some other retractors as well. There are also some table-mounted retractor systems. After retracting the tongue, you can either retract the uvula and soft palate, or make a stitching of the soft palate on one side. We try not to incise the soft palate, because in that case we can expect some swallowing difficulties. So with a deep bladed pharyngeal retractor, if you retract the midline incision of pharynx, you can easily see C1 arch and then C2 body. Then the next step is to drill the C1 arch and then see the odontoid process and drill the odontoid process. The difficulty with that surgery, actually, since at the odontoid process level, you are too far from vertebral arteries, you shouldn't get scared from injuring the arteries. But you can get complications like infection in this region, especially if you injure the dura. You can cause some meningitis, and you can have wound problems in the pharyngeal wall. We have collected the complication rate of transoral surgery. The diagnosis at this time, it is 2008, many years before. Most of them were buzzer invagination, then also odontoideum, odontoid tumors, old fractures, and infection. Total complication was about 48%, quite big numbers. But some, especially 14 of the cases, had complications because of occipitocervical fixation, not transoral surgery. 11% had complications due to transoral surgery. Swallowing difficulty, pharyngeal incision problem, reoperation due to insufficient decompression were the most common ones. There were also some systemic complications. In the last 10, 15 years, we have learned that we can make such surgeries, the compression of the craniovertebral junction anteriorly, with endoscopic techniques. One of them is the endoscopic endonasal approach. The other one is the transcervical approach, or endoscopic transoral approach may also be done. One of our speakers, Dr. Visocci Massimiliano, has a very nice paper. He's describing the advantages and disadvantages of them. It's a systemic review. For instance, if you make an transoral surgery, those green points may well be decompressed, but the red points are not easily decompressed. However, in the endoscopic transnasal approach, these points are well decompressed than those points, the red points. Endoscopic transcervical approach is to see the odontoid with a very oblique fashion. You have very small angulation, and then you can reach these points, but you have difficulty in the lower clivus and anterior atlas regions. So if you look at the advantages, endoscopic transnasal approach is a partial isolation of oral cavity, no need to tracheostomy, and necessity to feeding tube is low. However, endoscopic transoral approach is a direct approach, a good view, comfortable manipulation of surgical instruments, and radical removal of giant tumors is possible. However, with endoscopic transnasal approach, you can make resections in small pieces, and giant tumor resections are not very feasible. Endoscopic transcervical approach, complete isolation of the oral cavity, no need for tracheostomy and feeding tube. However, it's a very oblique approach, and and the resection is possible only in small pieces. There is one open surgery, anterior extrapharyngeal approach. You know, there are different incisions for that, but mostly we use that T-shaped incision, so then we manipulate the internal carotid artery, jugular vein, and submandibular glands, and here the hypoglossal nerve. We must be get scared about injuring the artery. These are some phases, and in a very deep position, we can see C2-3 disc level and a C1 arch, but in an oblique fashion. This is one of the cases I have done years before. This is a C2 osteoblastoma with a very huge soft tissue part. We have done extrapharyngeal anterior approach and remove this part and turn the patient back and make a oxalocervical fixation. This after almost 1 year, very nice fusion you can see here. There are some other approaches like Lefort 1 maxillotomy, which is a good for surgery of clivus and upper cervical spine chordomas, especially, or some other tumors. In this surgery, you make a sublabial incision from one maxillary tuber to the other, a mucoperiosteal flap in the midline to perform opening, and in the lateral parts to infraorbital nerves. And then by using an oscillating saw, you can make an osteotomy. You can also, if you wish, you can divide the maxilla in two parts. Yes. At the end, reconstruction is done using mini plates. After removing the maxilla, all the clivus is in your view in the midline. Median mandibulotomy or glossotomy approach is another very huge surgeries. At the startup, you have to make a tracheostomy in this approach. There are two ways. One is the median labiomandibular glossotomy. The other one is the mandibular swing approach. You don't cut the tongue in the midline, but you come from one side only, paralingual extension. This is one of the cases I've done by cutting the mandible, and this is after correction of the deformity and plating and grafting. Transhyoid approach, it is described, but I did not get any case for any indication. Transmandibular approach is quite better than this. I will not tell you the details about the lateral approach, but you can come very lateral by retracting the carotid and jugular vein dorsally or ventrally. Ventral retraction is better than you can go laterally, see the vertebral artery and dissect the region the lateral patient. Yes, we can skip this. I think this is what I want to remind you about the anterior surgical approaches to craniovertebral junction. Thank you.